eyelid ptosis. Symptom: droopy upper eyelid, visual loss often worse with reading and at night. Critical signs are droopy upper eyelid. Etiology could be Horner syndrome, third cranial nerve palsy, complete, partial, or aberrant cranial nerve 3 regeneration, 3. Myasthenia gravis, 4. Superior eyelid or orbital malignancy, trauma, history of eyelid laceration with levator in transections, contusions, injury to the levator, pseudostosis, contralateral eyelid retractions or proptosis, could be Duane syndrome. Workup. History: determine the onset and durations of ptosis. Present since birth, acute onset, all photographed. Mandatory documentation: must carefully check and document pupillary size and extraocular motility, even if normal. If anisocoria is present, measurements should be documented under light and dark conditions. Three, complete orbital examinations of both eyes. Measure and compare marginal reflex distance levator functions, upper eyelid crease positions of both eyes. Is there lagophthalmos? Any associated lower eyelid ptosis is often seen in Horner syndrome. Proptosis or eyelid lag may masquerade as contralateral ptosis. Exophthalmometry measurements are useful. 4. Complete ocular examination. Determine if there are associated pupillary or extraocular motility abnormality. Flip upper eyelids to determine conjunctival surface and superior fornix. Dilated fundus examinations to look for pigmentary change in adolescents and young adults who present with ptosis. Poor levator function and external ophthalmoplegia. Corneal protective mechanism. Document the presence or absence of preoperative lagophthalmos or bicularis functions. Alright. Treatment. Depending on the underlying etiology. 2. Non-surgical option: observation, tapering the upper eyelid open, an eyelid crutch attached to glasses in neurologic and myalgic ptosis, management of chalazion with warm compress and or excisions, eyelids or ophthalmic neoplasm with excision, surgical option, transcutaneous levator advancement, transconjunctival levator advancement. Follow-up. 1. Congenital. Close follow-up is required to monitor for the presence of amblyopia, caused either by occlusion or by refractive error, secondary to induced corneal astigmatism, abnormal head position, and exposure keratopathy. 2. Traumatic. Observations for 6 months before considering surgical intervention. 3. Neurological. We evaluate based on particular entity. 4. Postoperative. Acute. Monitor for infections and hemorrhage.